Hello, and I'd like to thank the organizing committee for inviting me to share this data of digital intervention of diabetes and fasting practices in Brunei Darussalam at this DAR Asia meeting. So we all know that diabetes and Ramadan is observed all over the world and is one of the 5 pillars of Islam and practiced by Muslims worldwide. In Brunei, which is an Islamic country, 82.1% of our populations are Muslim, and indeed they fast together with the rest of the world during Ramadan. The International Diabetes Federation, the IDF DAR risk score tool, is designed to help determine risk of fasting amongst patients with diabetes and makes a very good point to which we can counsel and talk to our patients about diabetes and Ramadan during the pre-Ramadan counseling. So for the rest of my talk, it's going to be about the study that we performed, which is called the Desired Study, the development and exploration of the effectiveness and feasibility of a digital intervention for type 2 diabetes mellitus. This study on diabetes and Ramadan is a sub-analysis of the Desired Study, which is a 16-week digital intervention study. Our aim was to risk stratify the patients who was in the Desired Study with type 2 diabetes who had an intention to fast and to study their fasting experiences. So what we did was have the participants in the Desired Study went through a DAR risk assessment scoring, underwent Ramadan-focused education with dietitian sessions, health coaches, and talking about nutrition and exercise guidance. At the end of the 16 weeks, we collected data, which is demographics data, the risk score, and we also, during this time, administered the DAR Global Study Questionnaire in order to see how the reflection of the study of their Ramadan experiences was. So the Desired Digital Intervention Study, as I said earlier, was a 16-week program which utilized health coach support via video consultations. Participants received weekly lesson plans comprising of multimedia resources. So we were sending out animated videos, articles for knowledge empowerment. They also underwent 7 sessions online with the health coaches and with the dietitian. Participants were equipped with a fitness band, smart weighing scale, glucometer, all set for data collection. In fact, we also gave them SIM cards for data because all this is done online. In this Desired Digital Intervention Study, 122 participants were recruited, of which 53.9% are female, with a mean age of 42.3 years, plus minus 9.4, and 87.3% were Muslim. The outcome of this study was very good because it showed significant improvement in all outcome measures, namely HbA1c, BMI, not seeing changes in lipid profile, apart from improvement in the triglyceride, and they also had improvement in the quality of life scores. HbA1c improved by 1.2%. So of this cohort of 122, we invited the Muslims amongst them to participate in this sub-study looking at diabetes and Ramadan. Now, the rest of the talk and data presented is based on these 105 patients who have participated in this. They have an average mean age of 42.5 years of age, more female than male, HbA1c of 8.9%, plus minus 1.2%. And indeed, if you look at this, only 5.9% of all normal weight. Remembering that this study was an interventional study looking not just at diabetes management, also looking at exercise and weight management. So in a way, I suppose it was skewed more towards having more overweight and obese patients interested in joining this particular study. They were all risk stratified according to the IDF DAR risk score tools, and only 23.5% scored low on the risk scale for Ramadan. Majority was moderate, and 20.6% had high risk. So with the 14 risk elements that's within the diabetes and Ramadan risk stratification score tool, all our patients got 0 on this front, because we only recruited type 2 diabetic patients. We excluded anyone with eGFR of more than 60. Pregnant patients were excluded. And in Brunei, the length of fasting is about 14 hours, and therefore they also scored 0. So for the rest of the other elements, risk elements, I'll go through it with you one at a time. And what we found was that majority, and in fact 78.4% of patients had diabetes diagnosed less than 10 years ago. And about the same range, about 70% was on glycoside or dimicron MR or any other sulfonylureas, and the rest went on other therapy, not including sulfonylureas or insulin. We had excluded anyone on insulin in this study. So the presence of hypoglycemia was reported only in 2 out of the 102 participants, and which is reporting hypoglycemia less than one time a week in one participant, and multiple weekly hypoglycemia in the other. HbA1c shows that the control was suboptimal, with only 11.8% achieving HbA1c of less than 7.5%. It was disappointing to see that very few conducted SMBG as indicated, 11.8%. And of these 11.8% who would do SMBG as indicated, and meaning that as discussed with their healthcare providers, 34.3% was in the low risk group, 54.3% was in a moderate risk group, and 11.4% in the high risk group. None of them had any acute complications in the last 3, 6, or 12 months, and only 2 out of the 102 participants, about 2%, had history of stable macrovascular disease. They were not frail, nor did they have any cognitive function impairment. Remembering that our cohort were in the younger age group, and most of them were in the working age group, and only over half of them reported no physical labor. Majority had no negative or positive experience, with 10.8% saying that they've had some overall negative experience. And so moving on from this group of 102 patients, whereby we've heard the risk, and majority was either medium or high risk, we then went on to conduct the questionnaire, which is what was conducted, the same questionnaire that was used in the DAR Global study. So we asked them of the intention to fast. And of this, only 84 of the participants, 84 of those who replied said that they had intended to fast, which translates to 97.6%. And of these who fasted, majority, 57%, over half, fasted for the full duration of 30 days, with a 9.5% having fasted for up to 10 days only. When we asked if they've received any education which is specific for Ramadan fasting, only 26.5% who replied indicated that they have received education before. 7 participants, which translates about 8% of those who replied or who filled in this questionnaire properly, actually said that they had to break fast due to illness, diabetes-related illness. And it ranges from either 1 day during the fasting period to up to 14 days. Specifically asking them about hypoglycemia, 4 participants, which translates about 4.65 who filled in the questionnaire, actually reported having experienced hypoglycemia. Of these, 2 of them had experienced it between noon to 3 p.m. and another 2 just before Maghrib time. Two of these participants had to break the fast as a consequence of their hypoglycemia, but they did not require any treatment from emergency or needing to attend any hospital or clinic. How did they manage their hypoglycemia? 1 reduced the frequency of the medication, 1 stopped continued the same medication, but stopped fasting thereafter. One did nothing, just continued the same. Another said, I changed the timing of my medication. We have very similar data with hypoglycemia for participants, reflecting 4.65% of those who replied had hyperglycemia, and of note, majority of this occurred during the eating time. So after they've broken the fast, and none of them required any treatment from a healthcare facility. They would manage the hyperglycemia by then cutting down the food, increasing the dose of the medication, and half of them said they continue the same, but then they stopped observing the fast due to hyperglycemia. So I like to just summarize the data in terms of IDF data rescoring. We had 56% who were re-stratified as moderate risk and 21% as high risk. Of this, our cohort, 78% had duration of less than 10 years duration, and about 70% were treated with the sulfonylurea class of oral hypoglycemic agent. The mean HbA1c in this group was 8.9%, and HbA1c of less than 5%, which would reflect better diabetes control, was only seen in 12% of the participants. Only a third of this cohort conducted self-monitoring of blood glucose, even though it was indicated. And majority of them was in the moderate risk group, and only 11.4% was in the high risk group. Only 2% reported previous presence of hypoglycemia before the Ramadan period, and 11% had previous negative experience as indicated on their risk score. With regards to the fasting experiences, I would say that Brunei still exhibits very high rate of fasting, with 97% of our participants who actually fasted, and over half, with 55%, fasted for the full 30 days. This is despite 32% who have only received prior diabetes education, and with 8% of the participants having got to break the fast due to DM-related illnesses. Of those who had experienced hypoglycemia, they were after lunch and before Maghrib. With hypoglycemia at the same rate, it was reported that majority of these 3 out of the 5, I think it was now 4 candidates, had hypoglycemia during eating hours. So I just want to conclude that the majority of patients will fast. Whatever we have re-stratified them, whatever the score is, right? Whether we've given them a high risk or low risk based on the IDF DAR 2021 re-stratification tool. The overall frequencies for hypo and hyperglycemia in the Brunei group remains low, 4.65%. However, we had equal rates of hypoglycemia as hyperglycemia. Therefore, I feel that more emphasis should be placed on educating patients on the management of hypoglycemia, and we see as frequently as hypoglycemia during Ramadan. And undoubtedly, the risk stratification tool is useful. It is useful to know what our patients are classified as, and we can use this classification to facilitate decision-making during the structured Ramadan-focused education and medication adjustment. Thank you.